Hello, and thank you for joining our live stream. We're here today with Dr. Carl A. DiRaimondo and Dr. Craig L. Olson. Both doctors are orthopedic surgeons with orthopedics and sports medicine BayCare Clinic in Manitowoc. Today we're hosting a Q&A type session on total shoulder replacement. Thank you for joining us today, doctors. Thank you. Let's learn a little bit more about our experts. Dr. DiRaimondo is board certified in orthopedic surgery and in sports medicine by the American Board of Orthopedic Surgery. He's also fellowship trained in sports medicine. Dr. Olson is board certified in orthopedic surgery by the American Board of Orthopedic Surgery. He is fellowship trained in shoulder and sports medicine. Visit our website for more on their backgrounds. Viewers, please feel free to ask any shoulder-related questions in the comments section. We'll do our best to answer your questions in real time. If we do not, don't fret. We will answer them sometime after the live stream is completed. So ask away, please. Gentlemen, with that in mind, let's get started. Let's start with you, Dr. Olson. Can you explain what is total shoulder replacement surgery?
Yes, total shoulder is replacing all the parts of the shoulder in regards to the bony structures, including the socket and the ball, which makes up the shoulder joint.
Okay.
So it's really a two-part replacement. When those surfaces are worn away and it's painful and stiff and doesn't function well, we use metal and plastic to replace those parts to reduce pain and restore function. So it's very much like a total hip or a total knee. It's just in the shoulder joint.
Okay. So you kind of answered my next question. Why would a person ever need a shoulder replacement?
Well, yeah, there's a lot of reasons, and really it's hard to truly understand the root causes for many of these shoulder arthritides, but essentially the articular surfaces of the joint wear away with time. Okay. Just as a tire would wear away when it gets to the 100,000-mile mark, the articular cartilage in the shoulder joint wears away. And eventually it gets to a point where bony surfaces are rubbing against one another, which are fairly rough, generate a lot of inflammation. And inflammation in the shoulder, which is swelling, causes a lot of pain. Okay. That pain then reduces function. The muscular structures around the shoulders gets weak. The weaker and stiffer the shoulder is, the more painful it becomes. And it's just a vicious circle that the worn out shoulder gets to that point where it's very debilitating to the patient.
Okay. Generally speaking, who's your typical shoulder replacement patient?
Well, it's a patient that has pain and restrictions of function, and usually the pain is the worst at night. And then, they have restriction in function and ability to do normal tasks of daily living. Mm-hmm. And really, these patients come in, we evaluate them, we see what kind of non-surgical options are available, and work them through those processes. And really, patients that can't get significant relief or restoration of function through non-surgical means, then the discussion about joint replacement of the shoulder becomes a bigger part of where we're headed.
Okay. Let's get Dr. DiRaimondo involved here. Hello, doctor. Let's talk a little bit about the basics of shoulder replacement surgery. You determine a patient needs shoulder replacement surgery. Then what are the next steps?
Well, there's a couple things. We need to get the patient ready, and that's the medical side of things. And similar to what we talked about previously in discussions with hip and knee replacement, those patients need to be optimized medically.
Right.
So that's an important piece. Then also it's our surgical planning, and the different companies that supply us with shoulder replacement have different means and how which we can template or plan our surgeries. Oftentimes now we're using imaging, typically a CAT scan that's done of the patient's shoulder prior to surgery, that helps us to generate a three-dimensional model and do a lot of the surgical planning preoperatively. So when we come to surgery, we have an optimized patient medically. We also have a very accurate plan that tells us how to place that replacement and the sizes that we're going to use.
Okay, so for our viewers who might not have seen our hip replacement video, can you talk a little bit about optimizing a patient? What does that mean?
Well, when we do a joint replacement, we consider that elective surgery. That doesn't mean a patient isn't in pain and wants it done in a timely fashion, but we want to make sure that they do well after surgery. So not all the patients that we're doing joint replacements, including shoulder replacements, tend to be in the mid or older age groups, and therefore they have other medical conditions, whether that's blood pressure, diabetes, heart disease, or otherwise.
Right.
We want to make sure those conditions are well managed, controlled, so when we do that surgery, we're not going to worry about a medical complication affecting our surgical outcomes.
Okay, so it's when those conditions, those situations are controlled, that the patient is said to be optimized for surgery.
Correct.
Okay, Thank you for that. All right, moving right along. What occurs during shoulder replacement surgery? Without getting too technical, basically what happens?
Well, generally, we tell patients, at least for us, this is a surgery we do at our local hospital. They're asleep for the operation. It's an open surgery. This is not done arthroscopically, but it's typically an incision on the anterior aspect or the front aspect of the shoulder. The diagram that you've placed up on the screen is one form of a shoulder replacement. What you're seeing is a ball structure, which is the upper arm bone. And then across from that, on the left of the screen, would be the socket. Okay. What we end up doing is we remove the worn out cartilage. So what this model or what this photograph is of is someone that's had a shoulder replacement where there's a metal or white ball, and they can see this.
Yeah.
You can't see the socket because the socket's made out of plastic, but there's a space between the bones that creates that. So that's what we're doing intraoperatively. To do this surgery, we have to open and close the rotator cuff or the muscle layers. So that's all part of the surgery itself.
Okay, so there are several types of shoulder surgery: total, partial, reverse. How do you know which option is best for a particular patient?
Well, I'll try to keep it as simple as I can.
Right.
We kind of break it down into two groups. We refer to there's anatomic shoulder replacement. So anatomic means we put a ball where the ball is, and we put a socket where the socket is. So people are like, oh, why would you do anything differently? Well, in order for the shoulder to function, you need an intact group of muscles and tendons called the rotator cuff. So if we have a patient with osteoarthritis or an arthritic condition that's worn out the joint, they have a functioning rotator cuff, meaning they can move their arm. It's just the joint arthritis limiting it. And what the picture you see on the screen, that's this anatomic. We put the ball where the ball is and the socket where the socket is to allow for good function. In patients that have a dysfunctioning rotator cuff, whether that's due to a chronic tear, muscle atrophy, and even in those patients that might sustain a fracture of their shoulder where we can't put it all back together, we want to do a replacement, then we utilize something called the reverse shoulder replacement, and there'll likely be a picture coming up. And the whole concept behind that is we put the ball where the socket was and the socket where the ball is. And what it does, it captures or holds the two in place, because you don't have a rotator cuff to do that. That's what the anatomic shoulder. But that particular design was kind of thought of and kind of pioneered in Europe over 30 years ago, and it's been in the United States now almost 20 years. Okay. But it's really allowed us to tackle those patients that have bad osteoarthritis but have poor rotator cuff or dysfunctioning rotator cuff tendons.
Okay, and you may have touched on this a little bit earlier, but how do you help your patients prepare for shoulder replacement surgery?
Well, some of it is also letting them understand what the expectations are. We talked about the lead into surgery, but patients have to understand there's a process. There's the surgery itself, but then there's the ongoing recovery. And I always tell patients the two most important times are the surgery, and then obviously the first 6 weeks or so when we're going to need to protect or be the most cautious with that shoulder, because it's important to let the muscle layers that we have to open and close heal. But by letting those patients understand they may be in a sling for 6 weeks, this is what they can and can't do, so they go into it with knowledge. Good news, once they're out of that sling, most patients can progress in a very steady and predictable kind of path to be back using their arms in a capacity they haven't done so within 4 to 6 months from that date of surgery.
Okay. And then in general, are there risk factors that maybe predispose some of us to shoulder health issues?
I mean, obviously, depending on, athletes that may have had traumatic injuries, that can lead to early arthritis.
Sure.
Laborers that do a lot of work with their shoulders, unlike the hip and unlike the knee, which are weight-bearing, stand-on, walk-on joints, the shoulder is different in that regards. So there is some element that might be what we say environmental due to use and abuse. There are some, conditions that run in families. There are some genetic components. The other one where we'll see this is patients that, maybe bad asthmatics or others that have been on steroids or medicines to help, help them breathe. That can also have effects on blood flow, shoulder, hip, where they can start to see conditions, something called osteonecrosis or avascular necrosis, where it damages the blood supply to the bone and leads to arthritis and ultimately shoulder replacement as well.
Okay, great. Thank you for your expertise, doctors. If you're just joining us, we're here with Dr. Carl A. DiRaimondo and Dr. Craig L. Olson. Both doctors are orthopedic surgeons with Orthopedics and Sports Medicine BayCare Clinic in Manitowoc. We're hosting this Q&A type session focused on total shoulder replacement surgeries. Gentlemen, there are many more questions for you, so we're just getting started here. Viewers, make sure you jump in with your questions or your comments. We'll be happy to take those as well. Dr. Olson, let's get you in the mix once again.
Good. Thanks.
What is involved with total shoulder replacement post-surgical care?
Well, we're working on two separate avenues, as Dr. DiRaimondo was mentioning. We're protecting structures post-surgical so that they can heal. But the other thing that we're fighting against is the shoulder has a tendency to want to seize up or freeze like a frozen shoulder. And so we work very closely with our rehab specialists, especially the upper extremity team, the occupational therapy team, to start initiating passive range of motion early on while the patient's still in a sling to maintain free motion. If you kind of imagine a farm gate with a rusty hinge,
right?
Over time, that hinge will not move. And what happens with the shoulder and a lot of shoulder surgeries is really blood and joint fluid, when mixed together, kind of forms epoxy. And so really what we're trying to do there is not allow that epoxy to set up.
Okay.
So, protecting the shoulder so it can heal, but also keep the shoulder moving so that it doesn't freeze up.
Okay. Generally, after shoulder surgery, how soon can a patient expect to return to normal activity?
I think that a lot depends on, the nature of the original problem, the type of surgery, what structures are involved in requiring repair. I think we're starting to become a little more lax in allowing our patients to move actively sooner, because it seems like now we really only have one structure that we're really trying to protect, and that's the anterior rotator cuff, the subscap. That's the part of the rotator cuff that we need to take down partially just to get to the joint to do our work to replace the shoulder. And as we get better and better with more modern repair techniques, we're able to kind of advance the rehabilitation and let patients have more and more active motion in the early phase. We're just really wanting to keep them from bringing their arm out to the side, because that's going to put stress on that repair that we do.
Okay. And then are there any restrictions on the surgically treated shoulder, especially after a patient has been given the okay from your office?
No, that's a really good question. I mean, really, once they get the okay, we want them to use that shoulder normally. The expectation is that when they're working with a therapist, that they, first get pain control. Second phase is getting motion. And then third phase is regaining the strength, which is really something that comes later down the line. You know, once they get the okay, we want them to do all normal activities with their shoulders. You know, we have laborers with, you know, that are unfortunate to have problems with shoulder arthritis at an early age. And, you know, those patients are really looking for solutions so they can go back and do, you know, fairly strenuous things. I know that, you know, 15 years ago when we were first talking about, say, reverse total shoulder, you know, some of the surgeons at major centers were saying, you know, tell the patients they can't lift anything more than their shoes. Oh. Well, you know, 15 years has gone by, and Dr. DiRaimondo will say the same thing. We know perfectly well that these patients are lifting things much more than their shoes. But, you know, there's a lot of technology going on in this area, which is allowing the surgeons to really provide, you know, better implants, which lead to better function, better recoveries. And I think it's a very exciting area for all of us, whether we do the anatomic shoulder or the reverse shoulder. There's so many nuances now that are really allowing our patients to have, you know, smaller procedures with less, you know, muscle cutting and structural cutting so that they can heal faster and return to function faster.
Okay, good. Thank you. Dr. DiRaimondo's next set of questions are for you. What are some of the most common questions patients ask when deciding whether or not to undergo shoulder surgery?
I think we've touched on a couple of them. You know, first of all, okay, you do the surgery, how long before I can use my arm? So that whole recovery period of time.
Okay.
And then also, what can I ultimately do? Are there any long-term limitations if I've had my shoulder replaced? You know, and obviously some of that's predicated on the age of the patient and the vocation they may be in or the recreational activities.
Sure.
So I always remind patients, whether we're talking shoulder replacement, hips or knees, you know, we can make them better from a standpoint of pain. We hope their motion's better because pain is less, strength is better, but it's not a 20-year-old shoulder. It's not a 20-year-old hip. It's not a 20-year-old knee. And, you know, like any machine, and it's a machine, it's metal and plastic, you know, how you drive it, shall we say, or how you use it will predicate how long it lasts. We've learned, and Dr. Olson can probably speak to this, you eliminate someone's pain, you can give them some guidance and they'll go out and do what they want to do. So, I mean, that's neat because they can do a lot that they haven't done before. Yeah. But that's where those questions usually lie. Okay, you do the surgery. How long am I going to be in a sling? When can I get back to driving? You know, things that just the milestones that are part of the normal recovery.
Sure.
But then ultimately it's, hey, I have a job. I work as a laborer. Or I have a job or I have an athletic type activity. Can I play tennis? You know, and certainly reassuring patients the vast majority can return to some level. But we just remind them, you know, it's not designed for 100 pounds of lifting above your shoulder height for the rest of your life. That's probably not the best activity for you.
Okay. All right, great. So what do you tell patients who are nervous about surgery, especially maybe somebody who has never, ever had surgery before, but yet they're facing, you know, total shoulder replacement?
Well, I mean, I think this is a lengthy conversation. Usually they don't walk in the door and we tell them they're going to need their shoulder operated on.
Right.
It's rare. So we've had an opportunity, you know, through a period of visits and time, conservative treatment, guidance, counseling, education, you know, where they finally cross that threshold from their coping, we're managing it conservatively, to they can't cope and they want to have surgery. At the end of the day, I always tell patients the decision isn't ours as the surgeon. We can say really all else we can offer is a shoulder replacement and these are the risk benefits and all the other stuff. It still takes the patient, you know, making that decision. And if they're not ready or there's anxieties that even despite that conversation remain, I'd say, hey, you know, take time, think about it, get back to us. You know, at the end of the day, we want someone that's committed, because if we're going to do a big operation, they have to be ready to go through the full recovery and take on, you know, the responsibilities that are going to fall literally on their shoulder once we do the operation.
Right. I see what you did there. By the way, so surgical procedure like a total shoulder replacement, how long does something like that take on average? Like an
well,
uneventful, uncomplicated surgery?
nice thin patient, less deformity, you can do it in an hour. But, it's probably a 90-minute surgery. Sometimes it can stretch out to 2 hours. And we're talking, some of these shoulders we're taking care of now, and Craig can attest to this, because, this ability to use this reverse shoulder replacements and from pretty significant deformities, they take a little bit more time. You're being more careful with the bony structures, the soft tissues, but, say 90 minutes, 2 hours tops, somewhere in that window. I tell patients, we don't rush, we don't dawdle, we're efficient. We want to do a good job when it's said and done.
Okay. So take a scenario where you've had conversations with a patient, prolonged conversations. The non-surgical tactics are not quite holding up yet. The patient is still skittish about surgery and elects to defer surgery. What are the risks of doing something like that?
I mean, I guess the biggest risk for us, the technicians that do the operation, it's further wearing of bone. And the big issue is it's the ball and socket. If you look at the shoulder joint, the ball is much larger than the socket. So it's not quite a golf ball on a golf tee, but it's that kind of scenario.
Okay.
And as osteoarthritis progresses, the socket erodes further and further. And so, as I mentioned, we've got the ability to take on some of these more complex or maybe more chronic arthritic conditions that the bone deformity becomes more severe, but that just makes it a technically more challenging operation. And I guess in theory, they may reach a point where conventional shoulder replacement may not be an option anymore.
Okay. Good to know. Dr. Olson, let's talk a little bit about the actual replacement hardware. And you guys kind of mentioned it in passing a little bit earlier, but tell us, what are these replacement parts made of?
Metal and plastic for a simple answer, but I just want to touch on what Dr. DiRaimondo just said about, waiting and deferring surgery. The beautiful thing that we have now is these complicated, as you say, hardware pieces now that can kind of accommodate some of these difficult problems where patients wear out part of the socket to the point where it's no longer a golf tee. And if you put a ball on it, it's always going to roll and fall off. So, I guess the key thing is, and we said this with our total knee and total hip talks, one of the most important factors about, deciding to proceed with surgery is, commitment from the patient, that the patient finally says, I got to do it. And like Carl said, now they're willing to do everything, in their power to make it turn out the best. And those are our ideal patients that do the best. So, I believe that, and I know my partners believe that. But getting back to the hardware, I guess that's the fun stuff. As I always say, do you go to Lowe's or Home Depot or Fleet Farm? But all of our implant manufacturers really come to the table with a big variety of tools for us to be able to accommodate our job. So the ball side is really a highly polished piece of metal, which is generally cobalt chrome, because we can get a very smooth, polished surface that isn't going to grate on the other half of the ball and socket joint, which is generally a piece of very high, dense plastic. Okay. But if you imagine metal having a little bit of a cheese grater characteristic, if it's rough, well, then it can grate that plastic and wear that structure down. So definitely with patients that are going to do heavy type things after surgery, we need to provide them with the best materials to minimize that wear process. So usually the ball is this highly polished cobalt chrome. The plastic is a very dense plastic that's shaped without defects, and also has some very modern techniques that we've talked about before to decrease oxygen radicals, which sounds complicated, but really those are the things that happen to plastic that, starts degrading it. And so the modern plastics that we use have built-in substances that really block the formation of these oxygen radicals. Usually the stem part that goes down into the bone, which these stems are getting shorter and shorter, smaller and smaller, are generally titanium, just because titanium has kind of a bending, it bends about the same way as bone, which makes it very compatible to bone and seems to, enhance the ingrowth and maintenance of bone density for that stem piece. There's then there's ingrowth pieces that are trabecular metal and other fancy metals that have porosity that let bone grow into it.
Okay.
So we could probably make this into a 3 to 6 hour podcast, having fun talking about the very cool space age metals that are available for us to use as surgeons.
Yeah, that sounds intriguing. Okay. And then how long are these replacement parts typically going to last?
Excellent question. I mean, we have kind of a shorter lifetime of experience with shoulder replacement. And so that kind of hurts some of the data that we need to really give good information. What I can say and what I see is that really it's the first year after a joint replacement, any joint replacement, that's crucial. These are where the complications of infection, loosening, component problems, blood clots, wounds that don't heal, all of these happen in that period of time. And that's why as surgeons, we see our patients at a much greater frequency early on to get them through that. Now, once patients get past that 1 year, then we're starting to see very high implant retention, meaning the same implants in a patient at a 15-year, some studies out to 20 years now, but it's 95%. Some studies are 85%, but all of this is kind of related to the nature of what type of patients we were caring for, what implants we were using. But really, once we get through that first year, we are starting to approach the kind of numbers that total knees and total hips are having, where we're seeing above 90% retention of implants at 15 to 20 years, which is great, because really what we want to do as surgeons is we want this to be the last shoulder surgery that the patient ever has.
Right. Great. So tell me, how do I know if my shoulder issue is worth a visit to one of you guys?
I guess I would say, how much can the patient tolerate? But I mean, shoulder problems in general, are predominantly pain. And of course, when we're trying to go to sleep, pain at night that keeps us awake. That's probably number one. Second of all is loss of function and inability to do certain jobs and, get things out of an upper cupboard, or just losing overall extremity strength that the shoulder, helps us to be able to do. I mean, when these things are happening, we always say it doesn't hurt to let us look at you and see where you're at and be able to, give you an appraisal of what's kind of going on. Why suffer? Why lose function? So, if a patient comes in early on, are they going to get a surgery right away? Most likely not, but they're going to get our opinion of what we see and maybe some options as what other choices we can do to kind of get that shoulder back on track, so these patients aren't living with the same amount of pain or dysfunction.
Well, and what is your advice when it comes to, shoulder health related issues, pain, stiffness, limited motor function, those types of things?
Well, I mean, if we let these problems go, they get worse. So, I mean, a stiff shoulder, really affects other body parts. It affects the neck. It affects the hand. Sometimes we see patients, with shoulder dysfunction, with numbness like carpal tunnel in their hand, pain in their upper trap that leads to headaches that goes up the back of the neck. I mean, dysfunction of the shoulder affects a lot of other structures, the upper back, the neck, the rest of the arm. And really, when it's not functioning well, it gets, increased use of the extremity that still does work. So the other arm starts to do double duty. So we see a lot of, snowball effects where patients are starting to have worsening of other conditions that really, if we can get them in and get them, to a therapist, get them on the right regimen to, try to restore function and reduce pain, many patients can do very well without a surgical treatment. So I don't know if I'm answering that question well, but I think, kind of covered all the bases. If you're getting worse, we can help you.
Right. Dr. DiRaimondo, can you offer some tips on how best to keep our shoulders healthy?
Well, I mean, it's like any other part of the body. It's how do you treat it? I think as Dr. Olson mentioned, pain in a joint is not normal, okay? Particularly pain that persists, that doesn't seem to be getting better. Better go in and see, us, a primary care, get a diagnosis. A lot of it is, control inflammation, kind of restore the normal function, whether that's through a formal therapy program or otherwise, but don't live with pain, don't live with stiffness, don't live with mechanical symptoms that are getting worse. If caught early, it's probably a simple fix. If caught late, it may be something where it's a surgery or it's a surgery that's more complex than simple, ultimately.
Okay. Well, thank you for your time and sharing your expertise, Dr. DiRaimondo. What's the key message you hope people come away with after this conversation?
Well, I think it's to understand that between myself and Dr. Olson here at Orthopedic Sports Medicine BayCare Clinic in Manitowoc, that obviously we have the capabilities, diagnosis, treatment, ultimately through surgical intervention for those patients that do have osteoarthritis or arthritic conditions of their shoulder to help them restore quality of life and function.
Okay. Give me a final thought from you tonight.
For myself?
Yes.
Well, I think, like I said, I mean, you've got two surgeons that are passionate about the shoulder, not just arthroplasty, but all aspects of the shoulder, but certainly in the realm of arthroplasty. Understand we're staying out there so that we understand current, past, and hopefully we'll have future, shall we say, advancements that we can bring to our patients in this market.
Great. Thank you so much. Dr. Olson, thank you too for your time and sharing your expertise today. How can potential patients connect with you and your practice partners for their shoulder health issues?
Well, BayCare has a very nice website. If you go to baycare.com, I'm sure it'll come up. We are the Manitowoc group that provides orthopedic services in Manitowoc. You can call.
You don't need a referral necessarily. If you're having a shoulder problem, and it may not be arthritis as we've discussed tonight, but if there's a condition that you need care for, give us a call.
Good. Excellent. Doctors, we thank you for your time today and for sharing your expertise. Thank you so much. And thank you to our viewers for joining us. If you have additional questions for Drs. DiRaimondo or Dr. Olson, please ask them in the comments section. We'll continue to answer them online. Both doctors are orthopedic surgeons with Orthopedics and Sports Medicine BayCare Clinic in Manitowoc. To learn more about the doctors and their experience or to request an appointment, please visit baycare.net/ortho. Thank you and have a great rest of your day.